All right, so I'm Anita Mahajan. I'm a radiation oncologist at Mayo Clinic here in Rochester, and I've been I actually treat children and adults with brain tumors, and I find that this group of patients that aren't quite children, but aren't quite the 50, 60-year-old patients do fall through the cracks sometimes. So I do think there's a special effort to manage the issues they have, as well as the types of tumors they developed. Here's my disclaimer, and I don't have any disclosures. So what are the topics that we wanted to cover today? What is it about the AYA population? So AYA stands for adolescents and young adults, and on the next slide I'll show what that means and what type of tumors they're predisposed to and the challenges they have. The three tumors that we're going to discuss, and I have to say it's quite a brief overview of these three tumors because there's a lot of information, and certainly we can get into the specifics of each as the interest goes. But we're going to be talking about what's the role of surgery, role of radiation, what's going on with chemotherapy and other treatments, and what are the current clinical trials for these tumors. And then specifically, what did this group of patients end up dealing with after they've been treated for the tumor? So what is an AYA patient? When you look at the definition worldwide, it's very interesting because it varies from country to country, and even within regions, there's some nuanced differences. The broadest definition is here in the United States, and in the NCI definition of what an AYA patient is anybody from the age of 15 to 39. So you can see that's a very broad range. And the issues that these patients will have during this time period is the 15-year-old will be going to school, the 20-year-old will be in college, in your late 20s, you start working, and then eventually you have a family. So these are social issues that can happen during a patient who gets diagnosed with a tumor during this time period. The tumor types are different than what you might get in a baby versus a 67-year-old. We also find that patients are less prone to trial participation, access to trials. Treatment tolerances are different than an adult or a child. The social needs and support for what an AYA patient is different than what a child needs or an adult. And yet these patients tend to live a long time. Now, the AYA subgroup is defined by an age spectrum here, 15 to 39. And on the right-hand side, you can see that there's a huge number of different diagnoses that these patients can have, the full spectrum of diseases, and brain tumors make up 3% of tumors that happen in this age group. So what happens with radiation in particular? I'm a radiation oncologist, and so just as an example, I wanted to illustrate some differences of what can happen in a young adult and an adolescent versus a child versus a grown-up. So the brain develops over the period of time. And we do really appreciate that in babies and children that there's a lot of neural development from the age of 0 to 3. But studies have shown that this neural development and pruning does not complete until a person is almost 30 years old. So you can see on the right-hand side, there's some illustrations of brain development. In a 5-year-old, there's a lot of areas of development. The blue is more mature, the red is the immature. At age 13, it's still not completed. And the brain development sort of starts from the back of the brain, and then it sort of marches forward. And it's not until you're in your 20s and even the late 20s, boys are a little bit slower than girls, interestingly, that the prefrontal cortex matures and gets to the full adult form. So impulse control and things like that and executive function resides in that area. And that does kind of explain why teenagers and young 20-year-olds don't always make the best choices. So the secondary malignancies, that's another thing with radiation. We know there's an age dependency. For instance, in thyroid cancer, children under the age of 10 are much higher risk of developing thyroid cancer after radiation. And as you get older, that risk decreases. In contrast, risk of breast cancer is actually higher when you're a teenager and a young adult because breast tissue is developing. So in a case where we're going to get into, if a patient is being treated for medulloblastoma, when you treat the whole spine, that breast dose is going to be, the breast tissue is going to be receiving some radiation if we use X-rays, and that could increase that patient's risk of breast cancer down the road, especially if you're anywhere between 15 and 20 years old. So again, this is something we realize, the tumor type, the side effects, and this particular risks and vulnerabilities vary between these patients and are specific to this age group. Medulloblastoma, this is a depiction of where it is. It's in the posterior fossa, typically within the cerebellum, or typically in the middle. It's been studied for many, many years, and we've learned a lot about it. So these are just very basic findings that were established for decades ago. One that's really, really important is that it's best to try and get that tumor out as much as possible. Over the years, the amount of residual disease after surgery has been studied, and we realized that if a surgeon can get it down to a very small area or nothing, there's a big difference in outcome. So patients who have almost nothing or very small area of residual disease do better than those patients where there's just a piece taken out or there's a significant amount. So the degree of resection is important. The other thing, unlike a lot of the gliomas and meningiomas that adults get, medulloblastoma has a tendency to spread. So it likes to travel in the fluid around the brain. So in the CSF, the cerebrospinal fluid. So there's a metastatic staging system. It's called the M status. M0 means there's nothing else. M1 means that they found some cells in the cerebrospinal fluid through a lumbar tap. M2 and M3 means that there's visible tumor on MRI scans outside of the main tumor. So again, survival is very related to the amount of disease that's outside of the tumor, the primary tumor. So this, again, is quite different for medulloblastoma. We end up having to do a more staging workup where we look at the brain, we look at the spine, we have to do a lumbar puncture. Different than gliomas, and very important when you have this disease that is completed and done in a timely fashion. And then radiation is really a very strong mainstay of the treatment of medulloblastoma. And early on, we realized we can't just treat the area of the tumor. And there were studies, again, if we concentrated just in that posterior fossa, patients didn't survive. There was 5% survival. And we realized we end up having to treat the whole brain and the whole spine because of that high risk of spread for the tumor. So once these larger fields called craniospinal irradiation, meaning the whole brain and the whole spine, once they started getting incorporated, patients started surviving. And so with radiation alone, suddenly half the patients were surviving. So these are three main things: getting it out, making sure we understand where it is, and then treating the whole brain and spine with radiation in a timely fashion. So the general overview, as I mentioned, surgery. First thing, get it out, remove the tumor, take the pressure out, restore the fluid. So alone, it's not enough. Radiotherapy, typically we want to get it started within a month of surgery. And there have been studies that suggest that the sooner we can get radiation going, the better it is for the patient. And there we're trying to get rid of any of the cells that have drifted away and also clean up the tumor where the tumor started. And so there, craniospinal irradiation, average risk is 23.4 gray, high risk is 36 gray. And that's the radiation dose that's required to the whole brain and the whole spine. And then we boost that area, like so where the tumor is, to 54 gray. So it takes 6 weeks to deliver the radiation. The chemotherapy, it is an adjunct to the radiation, and it's shown to help the radiation surgery. And so now it's really become standard of care for all children. And the typical chemotherapy is vincristine, CCNU, cisplatin, and it can take a long time. It's given during radiation and after the radiation for almost a year. So, in the old days, they used to take it out. It has a very specific appearance under the microscope. And of course, as you've been learning more and more, these days we've made it more complicated. because we understand more about the molecular subtypes of medulloblastoma. So historically, it used to be medulloblastoma, and it used to be 3 types. Now we have anywhere from 4 to 12 subtypes. And the interesting thing is that within these 12 subtypes, adults tend to get this red one here. It's called desmoplastic or sonic hedgehog, which is a pathway in the brain, and it's a normal pathway. This is the pathway that gets affected in at least 60% of the patients with medulloblastoma who are older than the age 17. So again, age-related differences in the types of tumors a patient will get, and our AYA subgroup is more likely going to have this red type of tumor called sonic hedgehog. So why is this important? It turns out that the different types of medulloblastoma do differently. The sonic hedgehog pathway patients, typically, as I mentioned, 60% of our adult patients have this pathway affected, and they end up doing better than these other types of group 3, group 4 that happen more in children. Interestingly, there's this other thing called Wnt pathway medulloblastoma, more common in kids, and these kids actually end up doing very well. So the prognosis and outcomes really is variable based on what type of medulloblastoma it is, and again, where it's gone, surgery, and everything else. And just as a point of interest, Sonic Hedgehog was actually named after this video character, and he's been made a comeback with a couple movies. So in the US, one of the things that's been quite challenging is that medulloblastoma is not very common at all. There's about 600 cases in the United States a year. 400 of those are in children, and about 200 or 150 to 200 are in the older age group. So it's been very hard to study them. We've been applying the things that we know from children into the adults, not knowing that it really applies. And we also realize now that a medulloblastoma in an adult is not going to be similar to that in a child. So there's been a national effort now. It's called the AMBUSH trial. And we're working through the system to get it approved through the NCI. And it's going to be a really cool trial because it's going to be taking our adult patients with medulloblastoma, and based on the type of medulloblastoma and where it's spread to, we're going to be studying these patients, their outcomes very, very specifically, and also testing a drug that is specific to sonic hedgehog mutations. It's called sunitinib, and we're going to see whether that helps patients do better down the road. And it works really well for adult patients who happen to have the sonic hedgehog pathway. So we're very excited, and hopefully this will get opened within the next year. And if you know anybody who has a medulloblastoma, direct them to a center where this trial is open. Ependymoma is another type of tumor that's more common in children. And as we learn more about it, management is becoming a little bit more complicated. Typically, again, all of these tumors are somewhat rare compared to gliomas and meningiomas and things like that. In the United States, about 1,400 patients are diagnosed a year, and it's less than 10% of all neuroepithelial tumors, which are the typical types of tumors that we see within the brain. Within children, it's about 10% of all childhood brain tumors, and most of those are diagnosed at a very young age. In children, most of the tumors are in the posterior fossa, and they can be pretty aggressive and challenging to remove. In adults, you can get the tumors either in the supratentorial or the infratentorial brain, and they have different management issues, including surgery and radiation and everything. And interestingly, ependymomas can develop anywhere along the spinal axis, and more than half of the ependymomas in adults are actually in the spine. And here's an example of what a tumor might look like in a patient who has an ependymoma in the spine. So ependymomas can happen anywhere through the brain and spinal axis, and each area has its own nuances. There's different types of ependymomas. Used to be easy. The old classification, essentially, it was these very low-grade ones, subependymoma, myxopapillary ependymoma, the grade 2s, which were the most common, and the anaplastics, which looked ugly, and there was a lot more mitosis and turnover. And of course, again, it's become much more complicated. And now each type of ependymoma within the spine, within the posterior fossa, and within the rest of the brain have different molecular pathways, different outcomes, and different age distributions. So I'll draw your attention to this row. For instance, in the spine, you can see that these brown ones, the subependymomas, and these green ones, the myxopapillary ependymomas, happen more in adults and less in children. Whereas these other types here, this one here, Ependymoma A, much more common in children and infants. So we're learning about what makes them different and our challenges in how to treat them effectively. So within the pediatric environment, there was a very large study. It was completed in 2007. It took 4 years to do. And here there was a very strong effort to look at the role of chemotherapy and radiation after surgery to manage these. One of the things that this study showed is that it's appropriate to treat very young children, patients actually as young as 1 year old or even 1.5 years old were eligible for this study and received radiation. And here, the major thing that was identified is that you need to get the tumor out as best as possible. If you have a complete resection, those patients will always do better than anybody who has something left over. So the surgeons have to have a lot of pressure on them to get these tumors out of the child's brain or in the adult brain to make sure that a patient's going to do well. Now, this is specifically for brain ependymomas. No spinal tumors were done. So we really can't tell the AYA population what to do with a spinal tumor because they have a different natural history. But if there is a posterior fossa tumor in an adult, we can apply these data. The current study, or actually, sorry, this is another study that's been recently closed. And again, you can see that our studies in children get very, very complicated, multi-steps. And we were testing whether or not patients would benefit from additional chemotherapy after the radiation. And it seems like if you have a tumor that's completely resected, you get the radiation, there is some benefit of adding 4 cycles of chemotherapy. So that is now the tendency, that the direction we're going. If an AYA patient has a similar situation, these are the data I could apply for at this point in time. So there's no prospective ependymoma study in adults and AYA specifically that's evaluating the very fundamentals of surgery and radiation at this point in time. So there are some ongoing efforts, and the CERN Foundation is a foundation that is very specific to ependymoma research. They are collaborating with the Children's Oncology Group. So they are looking both at adult and pediatric ependymomas. They have been looking more at options for recurrent disease, and most of them have been for using systemic therapies. So temozolomide, which is a common chemotherapy that many people are very familiar with. Lapatinib is a targeted molecule. 5-FU, which is an old drug that's been around for many, many years, and seeing if that was helpful in recurrent ependymoma. Omburtamab, believe me, I can't even say these long names anymore, but again, looking at the new drugs, and this one is a radio-labeled antibody to see if that was going to be helpful, and anti-angiogenic therapy. So I think, this is a good foundation to be connected with to see where are the new areas for development, especially in the challenging situation of when the tumor comes back. Now, germ cell tumors, another unique thing, and interestingly, germ cell tumors are very specific to the AYA population. They most often occur between the ages of 10 and 19. So that's that late teenage, early 20 years. Interestingly, more common in males. And in Japan, there seems to be a much higher incidence of germ cell tumors compared to anywhere else in the world. So you can see in Asia, Taiwan, Korea, Japan, they have a large percentage of these tumors in comparison to anything that we see in the United States. We don't know why. And it's helpful because we learn from their experience. These tumors are typically in what we call the pineal gland or in the hypothalamic suprasellar area. So if I see a patient and they have a tumor in these two areas, this is definitely something that we need to look at and think about while we're trying to figure out what this patient has. So germ cell tumors are weird because they are tumors. The tumor cells are the same as what we see in testes and ovaries. So you might ask, how can some tissues that are supposed to be down in the pelvis end up in the brain? And the thought is that these are leftover cells that were left over in the brain as the embryo was being developed. And so as we develop, it's strange, but there's these foldings, and this is a rest of cells that are left there. Now, within germ cell tumors, again, we can't make anything easy. There's two broad categories. One is germinomatous, and one is non-germinomatous germ cell tumors. So the blue ones and then these green ones. The reason we separate these is that the blue ones, the pure germinomas, we do extremely well. Patients are cured, and I rarely use the word cure, but we're talking with very straightforward, low doses of radiation. We were effectively curing patients in 95% of the time for a long, long, long time. The green ones, a little bit more challenging. You need surgery, you need chemotherapy, you need radiation, and their outcomes aren't as great. So one big separation, even though they're all called germ cell tumors, one thing that we have to think about. The workup here, again, is different because these tumors like to spread, and they can spread within the CSF. So we always do a lumbar puncture. And interestingly, these tumors will secrete tumor cells. So beta HCG is the pregnancy hormone. And these tumors can secrete that, and you can detect that either in the blood or in the lumbar puncture fluid. So we will check patients if they have these tumors or a tumor in these locations. Right off the bat, you can run these blood tests. And if they're high, it tells you, oh, this is going to be a germ cell tumor. And as long as the patient's not pregnant and anything else going on, the tumor is likely secreting these things. So this is one of the tumors that we have in the brain that you can actually follow them with blood markers. And it would be great if we could do this for other types of tumors, but we have it here. So typically when we have these patients, we do a beta HCG, an AFP, alpha fetoprotein, and we do that in the blood, we do that in the serum, we see how far it's gone. And typically, again, as I mentioned, our mainstay is going to be surgery if you can get it out, or for the tumor diagnosis, definitely radiation, usually bigger fields radiation, and chemotherapy. This is a typical paradigm for how we might treat a patient with germinoma. This is the pure germinoma. Patient has symptoms. We do the CSF cytology. We do the biomarkers. That means the beta HCG, the AFP, LDH, and this PLAB, but typically beta HCG and AFP. We check the fluid for tumor cells, and we do an MRI of the whole spine and everything. If we can't do a biopsy because it's too deep, we will go ahead and treat a patient based on these yellow markers if the beta HCG is elevated or the AFP is elevated. So there is an opportunity sometimes to avoid surgery in these patients, but oftentimes it's great to actually get the biopsy. And then if it's localized disease, meaning the tumor is only in that one area or just up in the brain in the two spots in the pineal gland, we can use radiation alone or chemo plus radiation. If it's spread, again, the cure rates are very high. We would use chemotherapy in a lot of our patients these days and craniospinal irradiation, similar to what we would do for medulloblastoma. The pure germinoma, our radiotherapy is very important. And what we do these days, if it's not spread, is we target the ventricles. So these are the ventricles in the brain, and this is the area that we're going to be targeting with radiation. Making sure that we can sterilize any tumor cells. It turns out if the tumor is just in the pineal gland or just in the hypothalamic area, we don't need to treat the spine because it very rarely travels down there. If it's just, we know it can travel in here, and we can't just treat the tumor alone. but we've kind of settled in on this middle ground of the whole ventricles as being the best place to treat. For the non-germinomatous germ cell tumor, again, there's pediatric experience because there's a more concerted effort to treat these patients. And a lot of the patients end up being in that pediatric under 18. Typically, it's been using chemotherapy, a second surgery to try and get it out, and then radiation. Results here, not as high as in germinoma, but we're doing better. We're up around 80% at this point in time with this triple modality treatment approach. There was an effort in the non-germinomatous germ cell tumor experience to eliminate the brain. And it turns out that wasn't very successful because what happened is that these tumors started coming back in the spinal cord. So now we know that we can't just get away with just treating the brain part of these patients. And so the newest study that we're looking at is actually doing a whole ventricle plus spine. And these are two separate patients. I didn't have one that was treating the whole ventricle and spine, but essentially what we're doing here is treating the ventricular surfaces, that complicated fluid pockets in the brain, plus the whole spine. And we're going to see whether that approach is going to be better for patients than just going ahead and treating the whole brain. Within this protocol, there's going to be surgery, and then there's chemotherapy, and the patients are eligible up to the age of 30. So even though this is a pediatric protocol, we're realizing we need to go up in age so that we can actually address the AYA population. Now, I'm just going to speak very briefly about proton therapy just because I can't help myself. And I think it's really relevant to their AYA population because two of the three things that we just spoke about, medulloblastoma and germ cell patients, both have a component of craniospinal irradiation. So specific to craniospinal radiation, in the older times when we just had x-rays and you just did it very simple planning, you can see we're treating the brain effectively. But when we treat the spine and we treat from the back, all of this radiation's coming out through the front of the patient. So you can see the heart, the lungs, the belly, there's stuff in the pelvis. As I mentioned, young ladies with breast tissue, that some radiation is going to get into that. So the tumor would be treated effectively. However, there's a lot of potential problems here. As our X-ray technology has gotten better, we're shaping it better. Now with protons, we're actually doing a much better job of treating the target, which is the whole brain and the spine, and eliminating that radiation dose that's coming through the patient. So the sense is that even in adults and AYA populations, and especially in children, everybody can benefit from proton therapy to reduce that exit dose that's happens with X-rays. And I think there's enough information now that I feel justified to say this, and it reduces the side effects even during radiation because there's less nausea, there's less swallowing issues, less bone marrow issues. And so hopefully overall the patients are going to do well. When we're looking at the brain specifically, when we use conformal radiotherapy, anything that's going to be in that high dose area, we do better with. So if you're using IMRT, conformal techniques, we're gonna be able to get that high dose area hugging the tumor better. Where protons actually add is that low dose. So anything that can be affected by low doses, like the eyes or secondary malignancies, that's where I think proton therapy will be helpful. So that low dose bath, the exit dose. Now, on paper, this looks great. On the screen, I'm always convinced that protons look better. In reality, what does it take to show this benefit? And this is just an example, and this is something that happened through my career. The first time anybody suggested that we should be doing craniospinal radiation with protons was in 2004. 15 years later, with an effort between when I was working in Houston and our friends in Toronto, combined effort, there's now some data that's emerging that outcomes with proton therapy and treating children specifically are worth the effort and time and expense to use proton therapy. but it took 15 years for this to come out. So again, our research, it takes a lot of commitment, and the information is always lagging the technology that we can deliver. It's a multidisciplinary team. All of our, we have to work together, and we have to be patient focused. AYA populations, you have to have a patient who or a surgeon who understands that this is not a glioma. This is actually a tumor that's more common in pediatrics. So there has to be good communication of the surgical team reaching into that pediatric information to sort of say, hey, what's new in medullo if they see a 20-year-old with medulloblastoma, or a 30-year-old or a 50-year-old. Where we give craniospinal radiation. These tumors can occur near the pituitary area. We have 20-year-olds, and suddenly we're affecting their hormones. So we have to work the endocrinology team to make sure that we're addressing the patient's whole body and needs, making sure that their testosterone, estrogen, thyroid hormone, cortisol, all of these issues are being followed appropriately. Eyes need to be evaluated. Some of these patients come in with eye issues to begin with. The posterior fossa can cause double vision. Pineal tumors cause their own issues. And then we're treating near the eyes too. Hearing can get affected by radiation, the tumor, or chemotherapy, in particular cisplatin, which is one of the one of the chemotherapies we use. MRIs, we have to talk to our radiologist, because we have to figure out what's an early recurrence, what's the type of tumor it is anything left? And on top of that, some of our patients might have underlying genetic issues that we should be aware of. Neuropsychology important, because we're affecting cognitive things, but also the emotional stress of going through this, and working with social work and psychiatry, super important. So in summary, I do think that AYA patients require specialized care for their specific tumor types within the brain. They fall between that crack in many ways, because adult practitioners might not really be on top of what's going on in the pediatric side. The pediatric guys kind of forget that this person's going to college and has a girlfriend and might have a kid. So there's a need to have an awareness of these issues. Patients are in this transition time. I think sometimes when I treat a 20-year-old and they've just left home for college and suddenly they're back home, it's not a happy place for them. And so these type of things, or they just got married or something like that. So it is important that all these things that are happening normally are getting affected. Radiotherapy is an integral component of many of these brain tumors. And we got to sort of walk both sides, both on the pediatric side and the adult side, because there are issues that we need to be aware of that aren't so obvious when I'm treating a patient with a glioblastoma. And these patients are going to live a long time. So Dr. Gandhi on a previous talk said, thinking about the person 10 or 15, 20 years down the road, absolutely 100%. This is what I'm thinking about all the time. And so we want to do everything we can to reduce those side effects, let the patients know what they're at risk for, counsel them about making healthy choices, and they need to have long-term follow-up for both the tumor as well as the side effects that might be associated with the treatments.